Hey, Lori. Hey, Lori. Can you hear me? Oh, you're on mute.
Yes, can you hear me?
Yes, and you look great. I love that jacket.
Thank you.
That's a great
TJ
color on
Maxx.
you.
TJ Maxx.
Oh, love TJ Maxx.
Listen, does my background look messy and ugly? Do I need to change anything?
No,
Can you see the dust on my printer?
no,
Okay.
definitely cannot.
Okay. I just want to make sure and
Oh,
I yeah, just
hello, everyone, and welcome. We'll give a couple more folks are coming in. Oh, it looks like everybody's in now, so we can go ahead and get started. Welcome to the webinar. This is the final webinar in the 2024 series of webinars offered through the end of this year by the Illinois Public Health Institute through funding from the Illinois Department of Public Health and the Community Health Assessment and Planning Grant to support the I-Plan or Illinois Project for Local Assessment of Needs. This training today will be focused on managing the community action plan cycle, and we're really excited to share that with you all today. Next slide. My name's Samantha Lasky, and I'm joined by my colleagues Lori Call and Jasmine Deskins. And we have one peer presenter today who you'll hear from later after our break, so please make sure to stay on for that. We're very excited to hear from Jessica McKnight from the McLean County Health Department. So very excited there. Here's our agenda for today. So as I said, we'll have a break about an hour or so in and come back. During that first hour, where we will be giving an overview of the process, talking about key partners in developing the plan. We'll have several poll questions in a breakout group, so we ask that you stay on screen with us to participate. And during our second hour, we'll hear from Jessica, talk more about implementation and implementation planning and tracking of the community action plan. And we'll have large group discussions, some polls, and some more opportunities for engagement. So make sure to stay on and stay active for that second hour. For our learning objectives, we hope that you'll be able to leave this meeting being better able to engage your community and partners in the development and implementation of your community health set improvement plans and develop those plans with measurable outcomes and be able to describe how to track community progress most effectively. If you've been with us today before, you've likely seen these already. If you haven't, welcome. These are our typical group agreements. We generally use these to create a more conducive learning environment. We ask that you let us know if there's any concerns or questions about these. We ask that you actively participate and stay present. Use your video camera as much as possible. Take space and make space if you can. Seek to understand different perspectives. We may need to ask that you allow the facilitator to move the conversations along. Any questions that you may have, feel free to ask in the chat or raise your hand. We want this to be as interactive as possible, and we'll parking lot what items we can't get to. And please complete the polls and evaluation questions. We're not the end all be all of experts, and if there's questions we can't address, we'll get back to them. We know there's plenty of expertise in the room though, so we invite you to respond to each other's questions, and the Q&A chat and the Q&A feature and the chat are both enabled. We want to start off with a couple quick poll questions to get an understanding of where we all are with these different learning objectives and the things that we're doing today. So our first question, I've just launched the poll. Our first question here is, what stages of the community health improvement plan do you typically engage your partners and community? And so that's our goal, developing our goals, objectives, and strategies, the implementation portion of the chip, tracking progress, or communicating or promoting awareness to the public. The next question is an open-ended question. And that's based on how do you ensure that your chip is being implemented effectively? So what work are you doing in terms of implementation? And finally, do you have a system in place currently to track and report progress on the chip? So everyone take a second to respond to these poll questions. We only have about 20%, 25% participation. So folks, feel free to answer the poll if you haven't already, or you can comment in the chat if you're having a hard time uh, answering the poll questions. And if you could, for the folks who have filled out the poll, feel free to put your name and your organization in the chat so we can see who's here today.
Looks like we're up to 37%. Love to hear from more of you. Here we go, 45%.
Couple more people. Okay, for time's sake, I think we're going to go ahead and end the poll. Awesome. So it looks like with our poll questions, a majority of us use engage partners and community in the first part, developing goals, objectives, and strategies, followed by a few of us in communicating and promoting awareness to the public. To answer our third question here, do we have a system in place to track and report progress? It looks like we're split pretty evenly here with about 40-ish% of us who yes, 29% no, and about 29% unsure. So we're kind of right in the middle there. And then for our last question, how are we ensuring that our chip is being implemented? I'd love to see these responses. We have folks following implementation work plans, conducting regular reviews and adapting as needed. Some of us are unsure. Quarterly updates for our Board of Health and identifying Board of Health agenda items that are chip related. Some folks are saying not much is being done. And others saying we don't have a systematic approach, but are planning for it in the upcoming cycle. We love to hear that. Implementing benchmarks viewed by the stakeholder, team meetings and regular updates, quarterly meetings and utilizing and tracking by surveys, and action teams with members from each area of expertise focused on the set priorities. You love to see it. Awesome. So next slide. Thank you so much for these results, and hopefully that'll be great level setting for this training. And I will now pass it over to my colleague Lori Call to talk about an overview of the process.
Great, thank you. I just want to talk a little bit about the I-plan requirements for this portion of your I-plan and how they are described in the administrative code. So you can see here on this slide that the right side indicates the requirements by the administrative code. These are pulled right out of the Illinois Administrative Code for certified local health departments, and they describe what IDPH, is looking for in your I-plan report. And so then what you'll see on the left side are those specific items. So they're looking for a purpose statement. You know, you do that for your community health needs assessment, but you also need to write a purpose statement for your community health improvement plan. They're looking to see a description of the process. So that includes how you engaged community, the community participation that you utilized, and as part of developing that community health improvement plan. And also that your plan was adopted by the Board of Health, and how the Board of Health was involved in that. Next, you're going to be ensuring that you have a description of each priority that you've selected. And remember that there's a minimum of 3 priorities that are required for the certification requirement. And that should have the data that really backs that up or justifies that as a priority. And you're also going to want to describe how it relates to Healthy People 2030, those objectives, and how it's connected there. So you'll want to utilize that resource, which we'll be sharing in just a bit in the training. You'll want to describe that the factors that are influencing the problem. And again, as we go throughout the training, we're going to talk about risk factors and direct and indirect contributing factors. Those are going to be the things that you're describing in your report to meet these requirements. And then finally, you will be required to have one measurable outcome for each of your priorities, one measurable outcome objective, and one measurable impact objective. And we're going to define those further in the training. You do have to, according to the administrative code, you do have to create a plan for how you're going to monitor the work. You don't have to submit that in your written report, but that is something that you're required to do. And also a plan for promoting awareness about the availability of these services and the interventions that you're going to be providing. So that's noted as in the administrative code. So just a quick comparison of the administrative code, the requirements that you have, and the public health accreditation requirements. It really mirrors each other. There's, not a requirement for a purpose statement, but that's because that's just part of writing the report, not necessarily the process. But you have to do all the same things for public health accreditation. You've got to list the partners who were involved in the CHIP process and describe all the information from the assessment that justifies your priorities. And the difference here, and it's not really a difference, it just calls it out more specifically by the Public Health Accreditation Board, is that you're reviewing the causes of disproportionate health risks or health outcomes on specific populations. So in your description, according to the administrative code, you have to define those risk factors and those contributing indirect and direct contributing factors. And here you're describing, really, you're just getting into understanding the differences by population. And you may have already done that, but that is a unique, unique part of the process. And also, FAB just splits things up a little differently, and they have the prioritization process as part of the CHIP, not the CHNA. So that's just a timing issue of when you conduct it in the process. And then I think that's about it. Yeah, so those are really the differences, and this is just a for your reference kind of guide. All right. And then in terms of the objectives, those are all the same. Improvement strategies, which you have to have according to IDPH and the administrative code. You have to have those also for the Public Health Accreditation Board, and you need to include a time frame that strategy is going to be happening, and who's going to be involved in that, who's accepting the lead role or the responsibility for that. And according to public health accreditation requirements, they would want to see that you are including proven intervention strategies that include a policy recommendation for at least 2 of your strategies in your plan. So that's something unique and different. But for all of these things, everything else lines up, and it's just a nice comparison. So you can, if you want to push yourself, If you're not accredited, you can make sure that the way that you're doing it is also in accordance with national public health standards. And Samantha, I'll turn it back to you to talk about key partners in the CHIP process.
Great. Thank you so much, Lori. So I'm really excited now to be able to dive into the community participation requirement of the CHIP process and how we engage our key partners. So let's take a moment to discuss how communities are involved in the process and reference back to what we were describing in our first responses in the Community Health Improvement Plan when it comes to how we're engaging communities. Some of the more formal ways communities are involved in the process is through the ongoing use of oversight committees who support the direction and lead, support in the direction and lead the CHA chip process. So in Apex PH, they call it the Community Health Committee, and other stakeholder groups are, they can go by other names. Through the development of action teams or the activation of existing coalitions is another way in which we can engage our communities in the process to help develop our plans and work through the implementation. Through the development of key activities needed to move the identified strategies forward, and the implementation planning is another way in which we can involve our communities. And finally, and or through the actual implementation of the plan, as well as the monitoring and promotion of public awareness. So ensuring that we are working with them to track our progress. I saw a lot of responses in the survey about we're engaging our folks to have quarterly meetings or review strategies, sending out information, and how we can utilize them to promote public awareness of the community health improvement plans. So in the chat, or feel free to unmute, we want to ask, what is the importance of gauging community in the process? What are some of the reasons as to why it's so important? So feel free to unmute or raise your hand or answer in the chat.
And just as a reminder, we're focusing specifically just on the community health improvement planning portion of the process.
We already have a couple coming in the chat here. Sorry, I'm multitasking there. We can adapt our strategies if things aren't going the way we need. Awesome. To ensure the priorities meet the needs or perceptions of our stakeholders. Great. Gives community members a sense of ownership. Yeah, that's really important. Oh, these are awesome. Any other thoughts on the importance of engaging community in the CHIP process? And feel free to unmute as well. Building
Mhm.
relationships, great. That's really important. Awesome. And feel free to continue to add some of those responses in the chat if you haven't already. Next slide, please. So very similar or essentially what a lot of folks were saying in the chat. Here are some other ways that we've identified that are important to engage the community in the process. The first is inventorying community resources. So inventorying or assessing community resources is a step in the I-plan process and detailed both in the workbook and in Apex PH. It helps to identify what assets already exist that the local health department can leverage and implement in their plan. It also helps, as some folks said in the chat, to align partners to move forward in implementing to avoid duplication in the work with partners who may already be making headway in the community or on their interventions that align with your priorities. And it helps to hold accountable the strategy implementation. So it shares accountability for moving strategies forward without sole and complete reliance on just the local health department to complete the work. You're sharing that ownership, so you're also sharing that accountability, which I saw Diana and a few others mention in the chat. It's an important step of the community and partner engagement process that can be overlooked, and especially with that first piece of assessing community resources. And we'll continue to identify that as a really important part of this process as we move forward. So for our next few slides, we'll continue to describe a few tools that can be used to complete this part, the inventorying community resources and understanding where our partners are at. The first tool that we'd like to share today is the Community Asset Map from ACHI, or the American Hospital Association Community Health Improvement Toolkit. This is a great resource for all the steps of the community health assessment, and several of their tools are also going to be included in the updated iPlan workbook that is forthcoming. That's still in development. We're really excited about. So this map, this tool does a few things here. It helps to understand what partners value. It helps to understand how important the partners will be to the success of the strategy. And finally, how much power they have over the activities and outcomes. So there are different types of assets within this tool that are described that the local health departments can utilize this map, utilizing these utilizing this map to understand these three things by looking at these different types of assets within their own communities. So the first here is human assets. So that's the organization's staff, board of directors, programs, memberships, target populations, where individuals may have expertise, talent, training, or skills that can be utilized at different organizations. The second is physical, so geographic location that's accessible to the public or the population you're trying to reach and provides public space and meeting rooms. The third is informational, so formal and informal networks of communication and participation in these formal and informal associations. And following that, we have political constituencies of elected officials and public and private institutions that may advocate for resources and policy changes. So, some of your strategies, some of your intervention strategies, some of the work that you may do may include policy, and political assets are important to note as well. And finally, existing interventions. So, initiatives that are already occurring in the community can be seen as an asset. One of the considerations when prioritizing should be existing assets and resources to leverage for implementation. So, some of this identification of assets may have already started when you prioritized. You should consider what assets and resources you have in choosing what to address and how to address it. So, when you're thinking about these assets and resources, it's important to note at the beginning of this work, for example, you may not want to put in strategies that you cannot implement if you don't have the resources. So, it's constantly identifying what assets exist, what resources exist in the community is super important. So it's important consideration and prioritization, and then again in selecting your goals, objectives, and strategies, and even then in the partners that you engage, because you need partners who may bring asset or who are assets or may bring those assets. So it's an important through line. Another tool that we have at our disposal that we think is really important to share today is from MAP 2.0 through NACHO. So one of the things in MAP 2.0 they have is called power mapping. So they have the power analysis and power mapping, and it can be used to determine how to engage stakeholders. Power analysis and power mapping is typically a working session with the tool you can see here, and we'll share another tool in a moment to determine who has the power to make decisions, who has the power to push and stop efforts, and who can ultimately influence steps in your iPlan process. For power mapping, using a power matrix like the one pictured here can help to compare the amount of power a stakeholder has in the community with how much they support the iPlan process. A stakeholder who has maybe a lot of power and strongly supports your effort may be a partner you want to work with closely, for example. Power mapping is a really valuable tool for individuals actively working in communities that provide a simple framework to better understand and leverage relationships and networks. Another example is maybe um, somebody who has a lot of power, but maybe is massively against your work or actively against your work, they are a group that has the potential to derail your work. So it's important to understand the support and power aspect. And as we move on to the next slide, another tool that goes along with this for MAP
Oh, real
2.0.
quick, Samantha, I just
Oh,
wanted to add in,
yeah, go ahead.
when Samantha's saying, they could really support or thwart your I-plan process, it's really about your implementation process. And if you're selecting a particular strategy or work in a particular area, your strategy is a policy initiative, who could support that? Who could work against that? And where do they fit on this power and support map here? So think about it like that, and that's something to consider as you're choosing your intervention strategies and your goals and objectives, as Samantha described.
Thank you, Lori. Awesome. This tool is also within NACCHO's MAP 2.0 called the Potential Partners and Opponents Table and can help to identify this within your priority health issue. And can be used in accordance with the power mapping. So it's a worksheet that asks specific questions for each partner. These questions relate to their impact. How are they impacted by the work? Their power, what type of power do they have? Their accountability to their work. So who do they report to? Who determines their budget? Who is their funder? Who influences them? And how their work is aligned. So, are they supportive of or against it? Do they have existing plans? Can we align with their existing plans and our work and what we plan to do? So, using this in tandem with the power mapping matrix or around the time that you're doing this can be really useful in answering some of these questions. Awesome. And I think the final tool that we'll be sharing today, we're really excited about, and I know our partners at IDPH are really excited about this too. This is a new tool that IDPH recently developed and presented at the Minority Health Conference last week, which I hope some of you were there. And this tool is used to identify existing gaps in community engagement. So this worksheet helps organizations, agencies, and coalitions identify and close the community engagement gap, which is the disconnect between well-intentioned outreach and authentic power sharing collaboration. So in this worksheet, participants will have many opportunities to understand not only outreach and engagement, structural factors that enforce inequities, readiness for co-creation, and develop actionable strategies. So if we move on to the next slide, I can share a little sneak peek. This is just one example of the many sections included in the extensive assessment that IDPH is in the process of publishing, and we'll, of course, share the minute it is published with all of our local health departments in our regular listserv because we're very excited about this. This section, for example, identifying the engagement gap, asks to assess the depth and quality of your existing engagement practices. Other sections include assessing power dynamics, determining where your work stands on the spectrum of community engagement and how to move forward, how to apply a systems change lens, action planning, and reflection. It can be applied to the I-plan process as well as any other work that requires community and partner engagement. So we're really excited about that. Next slide. Awesome. As noted earlier, there are many types of groups needed to work the move forward in each stage of the Community Health Improvement Plan or CHIP process. While assessing the assets of your partners and community members and how to engage them, it's also important to identify what components are consistent around effective partner groups. So, as I mentioned previously, it's important to have partners who align with your work and the priorities. It's important to have partners who can support the development of the goals, strategies, and objectives, our action plans and implementation planning. They may have content expertise or subject matter expertise, and they may be actively working on these priorities or have influence over them. They hopefully can regularly meet to manage the implementation of your strategies and move forward your objectives. And hopefully can work, the goal is that they can work collectively to establish and maintain accountability in the process. It's also important when developing and convening these groups to ensure characteristics for the success of the group in the process. So while you're engaging in your community health improvement plan, it's important to build and maintain buy-in and trust, ensuring that partners find purpose and interest in the work and work at the speed of trust, especially if you're engaging new partners or community members with lived experience who likely have had negative experience with government systems in the past or a history of exploitations, with communities experiencing disproportionate inequities. It's important to work towards not only giving partners and communities a seat at the table, but also engaging them and moving towards shared decision making and ownership to make the partnership worthwhile for them as well. And recognizing the importance of bringing the people most impacted by the health inequities identified with your priority needs into the work to have a say and ownership and consider compensation if possible to ensure equitable participation. And now, after describing all of these things and talking for so long, we'd like to hear from you all. So we're going to do just a short 10-minute breakout today where Jasmine will be putting in the chat our instructions as well as our sheets. And I believe we sent it out in advance of the meeting as well. So if you can't access it in the chat, you can access it in your email addresses, in your email inboxes. So today we're hoping to do a small breakout group where we will assign folks to random groups. Each group, oh, if you could go back one slide, Lori. Each group will get a different stage of the CHIP process, either developing the plan, so the goals, objectives, and strategies, implementation planning, the actual implementation of the work, or tracking and public awareness. And we'll ask that you answer these questions. Who might you engage in this stage of your process? Are there unique partners in your community who could contribute to this stage? Why would you choose to engage them? How would you go about engaging them? And what are the benefits of that? So I'm going to go ahead and open up our rooms now. And please let me know if anybody has an issue getting into the meeting. Have we put sorry, okay, perfect. Thank you so much, everyone. I'm going to open up the rooms now. Okay, Lori,
Welcome back, everyone.
I was hearing some great discussion.
great, me too. We can reshare the slides. Do we have time for a report out or do we want to move into?
I think just if we could hear just a couple quick things, just a couple highlights would be great.
Yeah.
Will, if you don't mind starting with group 3, I don't mind to put you on the spot, but you were talking about a partnership that's really been beneficial to your community with implementation, and if you just share that partner out and how that's been built.
So I was talking about, we have a really strong partnership with our local farm bureau. We're a relatively rural community, about 50,000 people total. And it's not a new relationship. It's one that we've built for decades. Our health department was formed in 1992, so it's still a relatively young health department. The Farm Bureau was actually very instrumental in supporting the health department when it was first voted in. And we've just had a lot of great luck. just working with them, whether it be we're in their monthly newsletter and we pay for a small ad. They open their doors and let us use their facility for our first COVID vaccine clinics when we didn't have a better place to go to. Engaging them just on little stuff like, oh, we're updating our wastewater ordinance, we're updating our sewage ordinance. So those types of things have really established that great relationship so that when we're dealing with our CHIP and even our iPlan, when it's fully implemented, that they're just a great resource for us to get information to. Partnering with them when it comes to making sure education gets to 4-H kids that are at the 4-H fair or little things like that. So it's just one of those relationships that's been built over many, many years, but they are a strong supporter of ours. They still occasionally come to some of our board meetings just to have a presence there to see what's going on. And we just always had a great relationship with them as far as I can remember.
Thank you.
Awesome to hear. Anybody else want to share? I know that Caitlin, not to put you on the spot, Daly talked a little bit about how she engages her partners in developing the plan. If you'd like to share a little bit.
Yeah, absolutely. So just kind of in doing that initial outreach, we're always kind of looking back to like our sector like designation map, whether that be like non-for-profit, healthcare, public safety. We have 13 different categories there, but just making sure that when we bring people into spaces that we have representation from at least one group to ensure we have that diversity.
That is awesome. Thanks, Caitlin. Great. I really appreciated hearing from all the small groups and getting the conversation going with each other. This has been really lovely. Now we're going to move into our next phase of this training today, focusing on developing the plan, and I will pass it over to Lori.
Thank you. Thanks so much. So I think you know that there are lots of parts to the developing the plan itself. And one of the first places that we recommend starting is really with understanding your priority. So when you choose 3 priorities, you want to take the time to really understand that problem, that priority, that health problem. IDPH defines the health problem as a situation or condition of people which is considered undesirable, is likely to exist in the future, and is measured as death, disease, or disability. And for that, we want to really understand the underlying root causes. And one of the tools that IDPH iPlan has recommended is the health problem analysis tool. There are also many other ways to do root cause analysis, and in the iPlan Basics training, we offered some suggestions on that. But today we're going to spend our time looking at the health problem analysis worksheet. And the first thing you want to think about is, for your health problem, what are the risk factors? And risk factors are simply determinants, excuse me, determinants that directly relate to the level of a health problem. So they're typically scientifically determined risk factors. It's not just things that we assume or guess, but there's some evidence base behind it. So overweight and obesity being a risk factor potentially for certain diabetes. This is true because diabetes can directly relate to the health problem of diabetes. There's much more scientific pieces behind that, but for the sake of time today, we're just going with the high level part. So that would be one risk factor. Another risk factor for diabetes could be, family history. There are lots of other risk factors. Then we want to go in and dig even deeper into direct contributing factors. And again, direct contributing factors are something that is science-based, evidence-informed factor that directly affects the level of a risk factor. So poor diet could be a contributing factor to some types of diabetes and affecting obesity. So that could be a direct contributing factor that we would be putting next to that risk factor of overweight and obesity. And then an indirect contributing factor is something that's going to be localized, community specific. It could be something that's happening in multiple communities, but it is something that is a characteristic, a factor that directly affects the poor diet, that direct contributing factor in your community. So if something that is like a lack of grocery stores that sell and carry fresh produce, or access to a grocery store that does, or access to farmers markets that sell healthy food, or even the proximity of fast food restaurants, and no other places that sell any kind of healthy food. Those could all be local community context specific. So when you're thinking about this, I always think of this as like the March Madness NCAA chart. It kind of looks like a chart like that. But when you think about this chart and you do work from the health problem, it's not like a logic model where you necessarily work backwards, but from the health problem, what are the risk factors? And for each risk factor, what's contributing to that risk factor? And that's scientifically based, and then what are the community factors that are contributing to that? Because where we want our interventions to focus is on our specific community interventions. If the reason that people don't have access to nutritious, or don't have eat nutritious foods is an access issue, that's what you should be seeing in the indirect contributing factors. If it's an education issue and they don't know what they're supposed to be eating, then that would be something different. If it's a cultural issue, they don't sell the types of fruits and vegetables that certain community members prefer and know how to prepare, then that's your indirect contributing factor. So hope that makes sense, and that's helpful, but this is a good tool to start your process off when you're looking at this sheet. So this is I was on the wrong slide. I didn't advance the slide to show you this, but this is what I was talking about when I said it's like, the NCAA chart or something, the March Madness chart, or any kind of tournament chart, it looks like to me, because we're narrowing down. But you start here with this health problem, you move to identifying the risk factors and the contributing and indirect. And this is where community engagement is really important and could be really helpful, because we can look up what the risk factors are. We might even be able to look up what the direct and contributing factors are, but really understanding what's impacting people comes from people with lived experience who are experiencing that, who don't have the access to the food or whatever it is, and they can tell us what that is best. So that's what we want to think about. As we move on to objectives, you're required to have 2 types of objectives for every priority. Now, you can have more than one objective, but you must have a minimum of 1 outcome objective and 1 impact objective. The outcome objectives is going to be a change, a desired level of change in a health problem or condition. This is a long-term objective with a 5-year or more time frame. In your I-plan, you're going to have 5 years, but it may take longer to really make a change in a health condition or a health problem. We know that, but you do need to have that 5-year time frame for your I-plan. So you're going to want to be realistic with the measures of potential change. For your impact objective, this is a measurable statement that's impacting the desired level of change in one of those risk factors. So impact objectives are going to be more intermediate. You can think of them as intermediate with a 2 to 3 year time frame. So again, when you write your I-plan, you're going to want to make sure that the end date is in 2 to 3 years. So here's an example. this one is related to underage alcohol use. So the outcome objective is to reduce the percentage of high school students reporting consumption of alcohol within the past 30 days from 30% to 20% by the year 2030. And we're using the Illinois Youth Survey as the data source. So that is a change in a health condition. And then we want to look at a change in the risk factor, which is easy access to alcohol. So we're reducing the percentage of high school students reporting that it would be very easy or sort of easy to obtain alcohol from 63% to 50% by the year 2028. And again, as reported in the Illinois Youth Survey. So these two outcomes show you examples. The places that you can find and look up potential examples are looking at Healthy People 2030. You can align with outcomes there. You can look at the State Health Improvement Plan, the SHIP. You can contact subject matter experts on the iPlan website who are listed by health problem or issue who have experience there. They can send you resources for where you can find good outcomes, or even help review outcomes that you've written to see if those are good outcomes. So those are a few resources for that. And I would also recommend thinking about ensuring that when you write your outcomes, you're writing them in a SMARTY method. So it's specific, which our examples were specific. They could be even more specific by focusing on a particular high school or a particular school district or community or what have you, or even a specific age group. It did say high school students. Measurable, they include a standard or benchmark to assess progress. And if you think about those examples that we provided, they had both the baseline and the targets of what we're trying to achieve. Achievable, they were not a 50% change. They were smaller incremental changes. And that's something else that subject matter experts can be helpful. So I encourage you to contact a subject matter expert in your topic area if you don't have one in your community that you're working with, that can help you really think about what's realistic and achievable to put in as the increase or decrease that we're trying to make, the degree of change, that they're time bound. And just remember that an outcome objective for iPlan needs to be 5-year time frame, and your impact objective needs to be shorter term, more intermediate, and that's typically 2 to 3 years. And then the two new things that you may not be as familiar with, this is not a requirement by IDPH for iPlan, this is just a sort of stretch tool, is to think about also making them inclusive. This is an opportunity to bring those who are traditionally excluded and groups that are experiencing greater inequities into the outcome. So how can we really ensure that we're bringing them in to either help inform this and or be part of and considered as part of the objective? The same here with equitable. It's including an element of fairness or justice to address systemic injustice, inequity, or oppression. And so we might think about a specific population group that we're targeting to improve this. We might think about the mechanism or the way, what is more equitable, rather than saying everybody's just going to eat more fruits and vegetables. We need to make sure we're increasing the access and the availability to all communities, things like that. So those are just a couple tools that I wanted to share, and I wanted to give you a minute to do some reflective practice. Just think about one of your priorities that you have, or in your iPlan, or a health problem in your community, and write an outcome objective and an impact objective. Just write that down on paper that you have or open a Word document and type one up. You don't have to turn this in. I will ask a couple of you to share it if you don't mind, but just take a couple minutes here to draft an outcome objective and an impact objective. And we're going to just be silent for 2 minutes while you all work on that.
You're on mute, Lori.
Thank you for our thinking music, Samantha. Am I sharing screen or I need to share again?
Not yet. You can share again.
Uh-oh. I lost my share. Sorry about that. Sorry about that. I lost my share. If anyone would like to share their example, you can do the unmute yourself and share verbally, or you can pop it in the chat. Where did my controls go, Samantha? Go
May have to.
share.
Did you find it?
Yep.
There we go. Oh, you're sharing the Zoom. No.
Yeah, it's coming.
Oh, perfect.
We good now?
Switch.
Display. Okay. There we go. Anybody want to share? Be brave. It's a safe place.
I'm not sure I got this right, but I'm going to go ahead and take a stab.
Thank you.
You're welcome. Okay, so when the outcome objective, diabetes is contributing to many health disparities in my community. Health food is becoming difficult to acquire as we're in a food desert. Access to healthy food would be my objective. 5-year time frame. I'd like to try to help lobby to get grocery store or something in our community.
That is exactly the work that would be ideal to be focused on. So even though it takes a long time to get a grocery store, your outcome objective is diabetes rates are, whatever rate your diabetes rates are this, and we want a reduction in diabetes rates by X amount by 2030 or whatever 5-year timeline.
Right.
So you got that there. Your impact objective is you want to increase access to healthy food through the
Yes.
provision of grocery store or whatever by 3 years, in 3 years. So you'd put that in your impact objective. So that's just perfect. And then we move our next phase, when we get into the next phase of work, is on intervention strategies. And your intervention strategy is policy, going to the city council, going to the county board to really help lobby for a grocery store. So you are 100% right on target. That's an excellent example. And if I could give you a gold star, I would. Thank you so much.
Thank you, Lori.
Yes,
Thank you.
I appreciate your bravery there. So we won't make anybody else have to share right now, but I hope that you'll see that that was painless, and it helps everybody to hear it. So thank you so much. We're going to go on, for the sake of time, to our next little quick exercise. And this is about making a SMART objective a SMARTY objective. So how could we make this objective that you see on the screen here more inclusive and equitable? And we're going to be taking a break very quickly right after that one more slide. But how could you make this more inclusive and equitable? Just write an answer in the chat if you have an idea. This says increase to 35% from baseline. Maybe you don't know the baseline right now, so you just put in from baseline the proportion of adolescents with mental health conditions who engage in local peer support program by December 2028. So I would suggest, and I'll see if anybody's put anything in the chat yet. Let's see, Samantha. Do we have anybody?
Not yet, Lori.
Not yet? Okay. So I would suggest one way is to focus this in on a population that is experiencing even more. The numbers are showing they're increasing more mental health issues. So I would say increase to 35% from baseline the proportions of LGBTQ plus adolescents with mental health conditions who engage in local peer support. That might make it even more inclusive and equitable. Or you could say increase to 35% from baseline the proportion of adolescents with mental health conditions who engage in local support program, specifically targeting outreach to LGBTQ plus students, so that you're not eliminating, that you're counting everyone, but that you're doing specific outreach to that subpopulation that may be more challenging to reach and is also experiencing more mental health issues. So that's one way you could do that.
And Lori, we have in the chat, we
Yes.
have an answer, two responses to the question.
Oh, great. So this
3.
would be, I would do outreach to art music classes in high school. So that's the way that you would do it. And also not just outreach, but the locations they live, communities where they live, great. And focus group with affected or target populations. These are all fantastic to get their ideas. And those really speak to what we're going to talk about next, which is the intervention strategies. So in this, example of the SMARTY objectives. We should have said SMARTY on this instead of SMART. If we're trying to make it more inclusive and equitable, how we might change the objective. But you all are doing fantastic in moving us along to the proven intervention strategies. So proven intervention strategies for this, the way we would come up with those, the way that we would be able to accomplish this would be doing outreach in a variety of different ways, holding a focus group to find out what the best ways are and how to engage them, and what some of the potential issues are impacting their mental health that we might be able to address, and going to things like art music classes to recruit folks. So great examples. And now we're going to look at what are some proven intervention strategies potentially related to this impact objective that we talked about earlier. So what are some intervention strategies to accomplish decreasing access to alcohol by youth? So that was the objective here, that we're trying to decrease alcohol by youth. What are the ways that we would do that? What are the intervention strategies? And go ahead and put some ideas in the chat. And while you're putting those ideas in the chat for that, I'm going to share a few resources and places that you can find interventions. You can look at the county health rankings, what works for health, Healthy People 2030, evidence-based resources, the CDC Community Guide, the CDC Community Health Improvement Navigator, Substance Abuse and Mental Health Services SAMHSA Evidence-Based Practices Resource Center, and the Rural Health Information Hub. I've got
Lori, could you
all
go
these on a slide here, so you can see those. Go ahead, Samantha.
Oh, never mind. You're
Okay, I got these on a slide here. And if you have any other resources that you'd recommend, let us know what they are. We are up for a break now. So I want to give you your break, but while you're, if you don't have to go take a call or do anything else, I'm going to turn back to this question here.
And we
And
do
I would
have
love it if
some,
you put something in the chat, but we're going to take, Samantha, is it a 5-minute break? 5-minute break.
and when we come
yes.
back, Lori, we can address some of the answers that 2 people have placed in the chat.
Wonderful. Thank you. Okay, 5-minute break starts now, and we'll play our music. Don't log out. Just you can just turn off your mute or view, whatever you want to do, or nothing, because Samantha's going to play some lovely music.
Okay, and we are back.
Okay, do you see the slides correctly?
Yes.
Thank you. Thank you. We had some really excellent answers in the chat. Thank you all so much. If you'll take a look at the chat. I'm just going to go backwards, but we had some exploring how young people are accessing their alcohol. That is so important. Rather than assume, hope we either have some data already. If we're partnering with other folks, they may have collected data already, or we hold some focus groups and or do some surveys to find out. But we really want to find out how they're accessing it, even partnering with law enforcement in case they know. That is so important. Do we need to be targeting the sales, illegal sales of alcohol, or do we need to be targeting, parents and older siblings around that? That's great. Compliance checks, retail, social establishments, education to parents on social host laws. That's so great. Many of our students, may be getting it from parents or older siblings. Partnering with community-based leaders, faith organizations, healthcare providers, both on the data and on the strategies. And then to really get even at the outcome objective, doing more prevention education at schools and making sure that there's accessible, affordable things, positive things for youth and teens to be doing. So some great ideas there. Retail outreach, education, and compliance checks again. So excellent answers. And here's one that says tangential but related. Please use any content. This is helpful getting your schools to participate in the Illinois Youth Survey. So there's information from Becky McFarland on how to get your schools to participate in the Illinois Youth Survey, and you will have some of this great data to measure around this. So thank you so much for your participation there. It makes such a difference in your learning and the training overall. I am thrilled now to turn things over to Jessica McKnight, administrator at the McLean County Health Department, to share what they've been up to. Jessica?
Yeah, thanks for giving me an opportunity to talk just a little bit about our community's unique collaboration efforts. So next slide. And giving you just a little bit of background of how it started. You may be familiar that hospitals have to also conduct community health needs assessments, and in addition to implementation or improvement plans every 3 years. Federally qualified health centers also must do community health needs assessments and implementation plans every 3 years. And then obviously local health departments were required to do our I-plan every 5 years. And in our community, we have 2 nonprofit hospitals, an FQHC, and obviously ourselves at the health department. So what we were having was at least 4 unique plans that were all completed separately, and everybody was doing separate efforts of work towards improvement. And so next slide. Since 2016, what we have done is come together to do one joint community health needs assessment and one community health improvement plan for all 4 of our agencies. Yep, thank you. And we are currently in our 4th cycle of this. So again, since 2016, 4th cycle then of a community health needs assessment and community health improvement plan. That does mean for us at the health department, though our I-plan is due every 5 years, we are one of 4 of these agencies. So we are working on the 3-year cycle of our hospitals and FQHC. So next slide. And so getting more into the meat of this, how do we make it work? And we make it work really from having a clearly identified structure and roles and responsibilities, which I'll go into more. Next slide. So first off being our McLean County Community Health Council. And that's our larger group comprised of over 40 individuals representing multiple sectors that come together and analyze the data that we have compiled for the Community Health Needs Assessment and help us select 3 priorities for the community to work on for the Community Health Improvement Plan. That group size can fluctuate. It has fluctuated over the years. We see new people come on, other people come off, but typically are about 40 to 50 individuals that we're maintaining in that council. So next slide. And the role of those council members, again, is to attend our council prioritization meetings and assisting with identifying those 3 top priorities that as a community we're going to work on for our implementation and improvement plan. And really the responsibility also to just stay in regular communication with our group, and join an implementation priority action team as appropriate if interested. And I'll talk a little bit more about those PATs later. Also, just stay up to date on our implementation plan as we release different reports, progress reports, and updates every year. And so that council, again, is just our larger group. And then next slide. We do have our executive steering committee, which is made up of the 4 agencies, the health department, our 2 hospitals, and our FQHC. And in terms of the largest responsibility of members of the council, where we are really compiling all of the data for the community health needs assessment, bringing that council together to look at that data, identify the priorities, and doing the out communication too. So putting out the reports to the council and community that are showing the progress on our implementation plan. And in terms of our meetings, we meet regularly. So since 2016, the steering committee of 4 have been meeting bi-weekly. So every other week, it takes regular communication and regular touch points on what we're doing and what's coming up, especially in those times as we're putting together the CHNA or getting the CHIP all together. So next slide. And I mentioned earlier, we have also, in addition to the council, priority action teams. And so we have 1 individual priority action team for each of the priorities, and members of our executive steering committee take ownership of those priority action teams and lead them. So for each of our 3 priorities for our community, we have a priority action team, and that's really where the bulk of the work gets done in terms of identifying those objectives, those strategies, the interventions that are going to be measured and actually in the plan. So what are we going to be doing as a community, measuring as a community, and reporting on? And their meetings typically whenever we're working on the community health improvement plan, they're more often, maybe every month, could be every other week. But until they get those objectives and the interventions and strategies and outcomes identified and put into a plan, they're going to be meeting more often. And then once that document is done, meeting a little bit less frequently. So maybe once every quarter, or maybe even less frequently, twice a year, just to touch base and also, give updates on how we're doing in terms of meeting those objectives or moving towards meeting those objectives, because we do an annual report on progress overall. Next slide. And so really, the thing is probably interested in benefits of collaboration. We are kind of, again, a unique group of working on one individual community plan. And so what we have seen is enhanced participation. So if you're thinking about, doing your own individual health department improvement plan, sometimes it's almost as if people get a little bit bogged down with how many of us are completing plans in the community, maybe multiple invites to multiple meetings. So our 4 agencies, we just have 1 meeting that our community has to participate in. And so we do get really good community participation in those events. And the attention that we get from our community for the work that we're doing in this collaboration, that really does beget then increased participation. So the four of us, we do know a lot of people and are able to then get them together. There's also a shared accountability. So not only, are we responsible for our own work, but we're responsible for the work of each other and this division of duties. So, I'm not responsible for the entire plan, which is a bit of a relief. You can expect that, it makes the workload much lighter. And also each of us in that executive steering committee, we do have our own strengths, whether that be data or maybe it's networking, reporting, planning, etc. We each bring a little bit something different to the table and then are able to divide and conquer. And together we really are better. So being in a collaboration, we're able to have joint efforts for our community. So rather than having four separate plans that we're working on and maybe not familiar with what each other are doing, we're bringing that together. Together, we're bringing those resources and we're able to complement each other's efforts versus maybe competing with efforts. So an example of that is our mobile health units. All four of us in that executive steering committee, the hospitals, the FQHC, and the health department, we all have mobile health units. So if we weren't aware of what each other were doing with those, we might all be trying to show up different places, providing the same services, and really just not having a good joint effort. Instead, we're communicating and identifying that one of us will take this area of the community. So the health department, we go out to the rural communities, and then maybe our hospitals are doing inside Bloomington normal, and maybe services are different so that we are reaching all parts of our community with the resources that we have. And then finally, a benefit of our collaboration is local funding from one of our foundations called the John M. Scott Commission Trust. They actually tied their funding that they award local grants to our community health improvement plan. So they do require grant applicants to identify one of the priorities and even tie the interventions back to those priorities for funding applications. So we make sure to, in our plan, identify all of those grantees and the efforts that they are doing and report on the progress as well in the other accomplishments. So again, that's just something that's
That's
really,
incredible.
it really is. You don't always see funding tying back to efforts, but they have made that a point to, in their, when they announce their RFPs, to have people tie that back and their efforts back to our improvement plan and the priorities.
Wow.
Next slide. Challenges, obviously with being on a 3-year time frame versus the 5-year I-plan time frame, the time commitment for being on that executive steering committee, it seems like as soon as you get one piece of the thing done, it's time now to do an annual report, or we just finished the community health needs assessment. Now we're working on the community health improvement plan. And so the time commitment there is a lot. And the work just never ends. Tracking activities is also challenging because of all of the efforts that we are including in our improvement plan. So not only just what the health department is doing or just what the hospitals are doing, but we're also involving our community partners in the council, in those priority action teams. So if they're providing us with their measurements and the outcomes and they fit, we're also tracking those activities as well. So that can be difficult to sometimes hunt people down to make sure you're getting the measurements back every year and identifying where to draw the line. So we want to be inclusive of as many of our community partners as we can. And example of that is we have a section in our implementation plan that is called now other related efforts. So it has almost now become as big as the work plan itself. So having to, as a executive steering committee, try to identify where to draw the line for that, because we do think it's important to look at those other efforts, but it's becoming harder and harder now to include all of the efforts. And next slide. And just a couple of the lessons that we've learned, or at least I have learned in the last few years of working in this collaboration. Always ask yourself who else should be at the table. Even though we do have a great involvement of our community in the council, the priority action teams, there's always somebody that you're probably missing. So even asking those priority action teams, our council, who else should be at the table, or look around and who's not here, because every year we do see more people want to become involved. So that leads into the also get out there and talk about it. And even though I always think everybody knows about this plan, there's always somebody that does not know yet. So we are going to, local media, we're going to our universities, different community groups, and just talking about our community health needs assessment, community health improvement plan, so that we're building awareness of that. And every time we do that, we get more interest in people becoming involved. And the longer the collaboration goes on between our 4 agencies, the more credibility we have and the more increased interest in our community becoming involved or tying back to these improvement efforts that we see. And really, the more collaborative efforts that we can have, I feel like we're better at moving the needle forward and making progress to improving outcomes. That is all for my presentation, but happy to answer questions if we have time for that.
Thank you so much. It's always exciting to hear about these collaborative processes, and we've served as a backbone for the Alliance for Health Equity in a similar way for many years. It's so rewarding to be able to bring folks together and not duplicate efforts. So I applaud you for all of that great work in 4 cycles or however many it's been so far, but I know it's been a lot. And you're right, when you make the plunge to go to a 3-year cycle from a 5-year, it really can be tough. Let's see. Any other questions or comments for Jessica?
I have a question, Jessica. This is Becky from DuPage County. I agree 100% that tracking the activities is so difficult. And yeah, what you said about like drawing the line, because it's like when you have priorities that are so broad, like substance use and mental health, it's like, oh my gosh, everything is mental health. So I know that like part of our role in like the CHIP is to kind of define those parameters a little bit. But I would love if you could talk more about how you get people, like literally, like, are you telling people to enter it in an Excel spreadsheet? Like, what are the nuts and bolts of how you're doing that?
Yeah, that work, it's a good question. That work really does get hammered out by the priority action teams. And so each of the executive steering committee members that are leading those groups, that they really are either meeting virtually and asking for that input, or they're emailing their groups. And luckily those priority action team, they're kept a little bit smaller. So we do have a pretty good interest in being in the council, but not everybody in the council wants to be on a priority action team because it's a lot of work. But that really is, it's just emailing people or asking them in a meeting to provide that input and the information. So if we set an objective of increase blank by this percentage, and here's our baseline, and here's the exact measurement, then we're going back to that agency and asking them to provide that specific data. And it really, whenever you're writing those measurements, if you can't measure it precisely, then we don't put it in. And the same thing with if an agency brings something up, if they're not willing to commit to providing that data on a regular basis, then it definitely does not go in the plan. It could end up in the other related efforts, but you have to be committed to giving us that data. So our dental clinic provides, some information on numbers of patients. So if we weren't able to then provide that report, it would not go in our action plan because we're not able to do that. And I think that that does help then keep that a little bit under control.
That's great advice. That's what I would have said as well. Any other questions? All right. Thank you so much, Jessica, and fantastic work. We're going to move on to implementation, and Samantha's going to take over there.
Great. Thank you so much, Lori. Also love to see all the engagements, saw a lot of hearts and claps and all that. So that's awesome to see. We really appreciate that. Um, great. So moving on to implementation. As identified, as we've talked about, and what based on what Jessica was saying related to the benefits of collaboration and challenges she's experienced, we recognize that time commitments and a lot of these other things are really some important challenges experiencing the implementation of this work. We want to continue to ground each other in the idea that partner engagement, which may be more work in the beginning of the process, helps immensely to the implementation and tracking of the stages of this work. By assessing community resources, we can consider what skills are needed for success, fill in any gaps in capacity, potentially tapping existing groups to fill those gaps with either our internal or external partners, have shared ownership over the work, as Jessica was mentioning, all to be successful in implementation. We also want to ensure, oh, I'm sorry. So we want to ensure that we're assembling teams and coalitions, implementation subcommittees, things of that nature. Next, tap those existing groups. As I said, they're working on your priorities, ensuring that the committees are representative of your community, identifying who's the owner and what their roles are, like Jessica was saying, to share that work, identify what skills are needed, and those gaps in capacity with staffing skills and funding. Next slide. So once you've connected with your partners and developed your goals, objectives, and strategies, it's time to develop that action plan and begin to implement it. For each strategy to be actionable, it's important to develop some of the following. This is actually the state health improvement plan is in the process of implementation planning, and you may be seeing that or participating in that work. And these are very similar things that we're currently doing or in the last process of doing to finalize the state health improvement plan. So one of those things is key activities. So each strategy will likely need to have actionable steps to achieve it. And you can describe those activities. Those may be very specific things like conduct outreach with these schools or connect to this work or develop a toolkit for this reason. And under the activities, it's really important to identify the lead, who owns the work or who owns the step. Is it the local health department? Is it a community group? Is it an existing coalition that is moving the work forward? The more you engage your partners in the development of the goals, objectives, and strategies, and all these other parts of the work, the easier it is to identify who leads what activities and shift responsibilities so it all doesn't fall on the local health department. Then you identify your other key partners. Who's helping to move the work forward? Maybe isn't the necessarily the main contact to who's accountable to complete the activity, but who you need to tap to be able to ensure the success of these activities under the strategies. And identify the timeline. What's an estimated or general timeline to complete the activity? Can you do this within the first year, within the first 3 months? Will this take a lot longer within your cycle in the first 3 years or in the 3 years before you start your next cycle? So these are all things that you want to consider under your key activities. You also want to consider these questions these following questions when developing the implementation plan to help move the work forward. So maybe consider again what resources are needed, what resources are needed. This will have been continually assessed as long as what barriers exist. A call to action. So how can we get our partners and community involved and invested in this strategy? What's their call to action? Why is this work important to them, and how can they help you move the work forward? What will success look like? So, thinking about metrics and tracking how to identify your metrics while you're still developing the plan. This will be really helpful when you get to that tracking phase of your work because you've already been thinking about it. Identifying finally, calling out and any specific community engagement or policy level activities. Those are particularly important and can be tasks that are shared with your partners. It's also, if we could click one more time. Yay. It's also super, super really important to consider funding as as you all local health departments develop your strategies and begin action planning. At this phase, local health departments must consider what funding they already have access to and what possible funding sources they could tap or apply for to increase their ability to achieve these strategies. That's, I think, one of the most important things to consider as you're developing these key activities.
Thanks, Samantha. I wanted to just also note, as Becky was talking about and Jessica, how do you track all the things that people are doing? And I love what Jessica said. If, people can't agree to report data and do all these things, we're not going to put that in the plan. But there's these other things like call to action, like how can other people support this work? And that's some ideas. You don't have to do this, but it's, what are some ways that the community could get involved, or how could the school sector or law enforcement support this work? It's a way to start building other partners. And if they are doing some of these things, maybe when you revise the plan or next time, they do become someone who's a partner in the actual plan and they do begin reporting those activities towards progress. So it's really just a way to start building and working in that direction. So I just wanted to mention that. And we're going to do just a really quick piece on tracking progress of the community action plan and how you can set that up. This would require a full day training, to really do, but these are just some resources and things to think about. So in this final stage of the process and training, let's talk about tracking and monitoring. So, what are you already doing to collect data or document the work? Many of the things that you may choose as a priority might be something you're already focused on, might be something you have a federal or state grant for, or some other funding. So, what's the data you're already collecting? That could be an easy win to help with tracking progress. What resources do you already have or tools? Excel is a great resource. We don't have to have buy into something like Clear Impact or another platform. We can build something in Excel or Smartsheet or something else that multiple people could contribute data to. It's just getting people to want to report that data and to do it on a timely basis. How often will you really be coming back and looking at that data? If people are reporting it and no one's looking at it and responding, they're going to stop reporting. So thinking about that, are you able to get reliable data, or how reliable is the data that you're accessing? Where can you start on measuring a couple indicators that are fairly easy? And maybe you're not measuring everything, but starting somewhere. And where do you have experience or capacity and time? This particular program can report fairly easily, so let's start here. So those are just some things to think about as you're starting a tracking and monitoring, or you're trying to revamp or improve a tracking and monitoring system. For the infrastructure to support monitoring, it's really important that you think about developing a team, and this could be a team in-house and with your community partners. So this is another place to involve community partners. Sometimes when we've worked with our hospital partners or the United Way as a partner, they may have some tools that would be helpful for tracking and being able to have people collectively report data. So think about that as well. The expertise on action teams. So if you're using something like for each of your priorities, how Jessica said priority action team, she has a team for each of those. Maybe someone with expertise or tools there that can help with that. But really determining what is the accountability, what's the oversight that you're going to provide. Jessica talked about that executive steering committee. Are they looking at the data on a biannual basis, on a quarterly basis? You know, who's looking at that when, and what's a way to do that? And thinking about how you're going to use the results. It's great to be able to spotlight success stories of where you have been implementing and you can show that implementation in a story, and even help have the media pick up those stories for how you're implementing. It's just incredible to me that McLean County has been able to get a local foundation to align the way that they fund with what's in the priorities of that plan. I'm so excited about that. And I think these success stories and being able to get this out more and to show the robust nature of both the assessment and the way that you're tracking progress could really entice some local funders or regional funders in something like that. So some of the ways that you can, tools for documenting activity, you know, first there has to be an expectation that we're actually gonna track and document what we're doing. We're gonna count this because we're trying to measure it, that we integrate it into any existing processes, whether it's within our own organization or the collaborative, the partners, or what have you. Trying to keep it as simple as possible for how people can report the data on implementation, on what they're doing that's actually counted as an implementation activity for a strategy. Keeping the focus of the committee on the action team and the priority issues, all of that really by meeting regularly. I love hearing that Jessica's meeting with that core executive team every other week. That is a really high frequency for those folks to be meeting, and it keeps them, you know, really the eye on the prize there. Where you're using the data to identify improvement opportunities. We don't want to find out at the end of our 3-year or 5-year cycle that we haven't achieved what we intended to achieve. We should be knowing incrementally all along. So even at our activity level, are we on target with those activities? If we said we were going to work with law enforcement to do compliance checks, are those compliance checks happening? If they're not, what is the barrier? How can we get that back on track to implement as many compliance checks as we wanted to implement? Things like that. And really get engaged in that quality improvement activity, which I'm going to touch on really briefly. So components of a measurement plan, and I'm going to go through these components by showing you a sample. This is not a requirement. This is just a sample tool similar to what I've used with a lot of different communities and projects. Here you'll see the example. I'm just using the same examples we had before for the outcome objective and for the impact objective. And here I have added an intervention strategy related to that to coordinate the provision of beverage alcohol sellers and servers, education and training, and that is targeted to sites that have had the most underage sales of alcohol to minors. So this is one where the health department's not delivering this service, but the Illinois Liquor Control Commission is, and we're just partnering with them for that training by identifying, giving them data on where the compliance checks showed that the most underage sales were happening. So again, we're doing very little there. We just would need others to help us. So in this measurement plan, we have the baseline data and we have the target that we're trying to achieve. We have the data source that we're going to use to measure that and the timing of when we're going to measure it. For the impact objective, same thing. And for the intervention strategy, this is going to be process data. So we're looking at the number of sites that the baseline is the number of sites that served folks, underage folks, and we have a target of how many we want to address, how many sites we want to address, or what have you. And we're going to be collecting that through training records. So that's the way it's conducted. But Bassett or the Illinois Liquor Control Commission would need to share that information with us. And then I have another site here, another type here is the alcohol sales compliance checks are conducted and how many sites and what's our target and who's doing those compliance checks, and how are we getting that data. And then another strategy potentially is maybe this one's one the health department's doing, or maybe this is one that another partner is doing that is funded to do substance abuse prevention. The number of parent presentations educating on the dangers of underage drinking and consequences of providing access, which is basically the social host laws. The baseline is there have been 0 presentations in our community, and we're going to target to do 3. We're going to count training records and sign-in sheets. So this is the plan. And then you would create an Excel sheet to be able to put the data in that would match this. You just really add on to it. This is one way to think about it. I'd like to hear how you're doing it. If you want to put a note in the chat, I'm going to continue to go through a couple slides. So we're just a little behind in time, but I really want to hear any ways that you all are collecting data or creating a measurement plan. If there's something you think is missing in this or could make it even better, we'd love to hear that and share it with you all. So key evaluation activities here. I think I've talked about most of these things, so I don't think I need to spend a lot of time on this at all, but take a look at these evaluation activities. And remember that most importantly, the reason that we're monitoring this and evaluating this is because we want to be able to show that we've made progress. We want to be able to show the impact of our work and engage more partners, more funders because of it. Funders are going to want to see that they're investing in something that we've proven works in our community. And so that data is going to be really important for that. But we can't wait until the end of doing all this to see if it's on target. So if we said we were going to do so many compliance checks and we haven't even done half of them in the middle of the year, we're going to need to look at why are we not getting those done? What's happening there? Or if we said we were going to do these parent education sessions, but no parents are showing up, we need to figure out what's going on. So this is when we apply quality improvement. What are we trying to accomplish? Maybe we need to engage more parents to show up to the education courses, or we need to increase the number of compliance checks that are happening. So we really just go through the PDSA cycle, the Plan, Do, Study, Act by what are we trying to change? What's our data telling us? And what changes can we make that will result in an improvement? So for this one, what changes that will help us make an improvement? That root cause analysis, or understanding why are they not showing up? Well, why this? Why that? Just digging down in those 5 whys can help us understand what the improvement is. Maybe it's the night that it's being offered. Maybe it's that a note was being sent home about it in the school bags and the parents aren't getting the notes. What's another way to communicate with the parents that doesn't depend on the children bringing the note home? So whatever that is, we just need to figure that out, and we need to try an improvement in the way that we're doing things to accelerate that change. So that's really just the Plan, Do, Study Act. We've done a training on that. You can see, you can use this QR code or click on the link to access that training on QI, and that will help get you on track. We are down to our last 2 minutes, so if you have a question, please put it in the chat and we will be happy to answer it. We'll follow up if we don't have the answer or can't answer it fully on this call. But we do thank you so much for your participation. And while you're thinking about any potential questions, we want to open the poll for your feedback on today's training. We value your feedback and we really try to incorporate it all to make this the best use of your time and hopefully beneficial to you. So please take a couple minutes and answer this poll question. We really need this to report to the funders. So please answer the poll. And if you have any questions, put those in the chat. And poll questions are up now.
If you go
And
to
I'm
the
not seeing
last,
anyone answering, but if you could go ahead and start answering. It's very short. There are just 4 questions with an additional feedback option. So it moves really fast.
and Lori, if you could go to the next slide as folks are doing that real quick.
Yes, absolutely.
We also wanted to share that we are in the process. We're working we've developed our final TA session, which is on November 20th from 1 to 2 p.m., where we'll be hearing from the Illinois, the data stewards. One, it will be reporting out on and doing a demo of the Illinois Hospital Report Card website and the Illinois Community Map. And we'll also have Graham Briggs from IDPH who will be sharing about the data suppression policy.
Well, those sound great.
Mhm.
Thank you so much for that. Looking forward to that TA session November 20th. So any of your folks who work with data, it does not have to be an iPlan administrator. It doesn't have to be the local health department administrator, but any of your folks who work with data should feel free to join that session. You can share the link with them. We've changed the way that these trainings are working so that you can share the link. And thank you so much for your participation today. Jessica, thank you for your great presentation. It was really helpful. And we really appreciate everybody actively participating because it makes it so much more beneficial to all of you. So thank you and have a great rest of your week. Okay. We have evaluation results from everybody who is on that now. We can close that poll.
Oh, I think 1 or 2 more people are still filling it out.
Oh, okay. I'm sorry. I'm so sorry.
No, you're good. I'm going to keep it open for another minute or so folks can fill it out. If you haven't already, feel free to hop off. Or if you have filled it out already, feel free to hop off the call.
Oh, okay.
And Jasmine, we can go ahead and stop the recording.